evening, everyone. So this evening, our fellows from the University of Santa Tomas Hospital will present an interesting case of a large mediastinal. Let us welcome Dr. Jamie Joseph. Let us all stand for our PAPP. A large mediastinal mass. Let us welcome the chorus.
interesting case of a mediastinal mass. So these are my objectives for this presentation. So we are presented with a 5-year-old male from Tondo, Manila, who came in due to difficulty of breathing. He was apparently well until 8 months prior to admission, when the patient had dry cough, with episodes of hemoptysis, coughing out fresh blood amounting to 1 cup. There were no other accompanying symptoms at this time. He was then brought to a tertiary government hospital, where chest X-ray revealed a non-homogeneous mass. Where the patient revealed a non-homogeneous opacity at the right inner thorax, suggestive of a mediastinal mass. Heart is not enlarged and no shifting of mediastinal structures were noted. Since the patient had no recurrence of hemoptysis while under observation at the emergency room, he was discharged the following day and advised workup as outpatient. So further workup was done at the same institution. Tumor markers were within normal limits during this time. Chest CT scan showed a non-homogeneously enhancing solid soft tissue mass measuring approximately 10.9 by 7.8 by 7.1 centimeters at the right anterior mediastinal, displacing the heart to the left. They then proceeded with a fine needle aspiration biopsy. However, results only showed a hemorrhagic smears, which was inconclusive or could signify an unsatisfactory tissue sample. He was then advised consult with a thoracic and cardiovascular surgeon, where excision biopsy was also advised. However, they refused and was then lost to follow-up. During the interim, the patient still had persistent dry cough with easy fatigability and weight loss. There was no recurrence of the hemoptysis. However, an irregularly shaped non-tender mass at the right upper chest wall, measuring 1 centimeter at the widest diameter, was noted that slowly increased in size. Since the patient was not in respiratory distress, no consult was done. Until 3 days prior to admission, the patient developed fever with productive cough and dyspnea. They were then brought to a different hospital where he was assessed to have pneumonia, given oral cefuroxime and salbutamol nebulization as take-home medications. However, due to non-improvement of the symptoms, they sought consult with a thoracic and cardiovascular surgeon who advised biopsy to the patient, hence admission in our institution. So the review of the systems was unremarkable. He is a known asthmatic with no maintenance medications. Immunizations were from the local health center with no booster doses. Family history is positive for bronchial asthma, colon cancer, and hypertension. Socioeconomic history was non-contributory. So upon arrival at our institution, the patient was in respiratory distress, ill-looking, with the following vital signs. He was tachycardic and tachypnic at 42 cycles per minute, with noted desaturations at room air. He was also noted to be pale, with pale skin and pale palpebral conjunctiva, no palpable cervical lymph nodes. Chest examination showed a fluctuant skin-colored non-tender mass at the right upper chest wall, measuring 2 centimeters at the maximum diameter. Lung examination revealed a symmetric chest expansion, intercostal and subcostal retractions with dullness and decreased breath sounds at the right anterior chest. Apex peak was displaced at the 5th left intercostal space, anterior axillary line. No murmurs were appreciated. Abdominal, genitourinary, extremities, and neurologic examination were all unremarkable. So these are the salient features of our patient.
Are there any questions regarding the history and the physical examination?
So in a patient with a noted mass on chest radiograph, it is important for us to localize the mass to narrow down our differential diagnosis. Distinguishing between a pulmonary or a mediastinal mass is actually difficult since both forms hazy densities that may form your silhouette sign, wherein the normal borders of the adjacent thoracic structures are not visualized. So as a guide, pulmonary masses would usually abut the mediastinal surface, hence forming your acute angles, as seen here. Meanwhile, for the mediastinal masses, it would usually sit under the surface of the mediastinum, hence would form your obtuse angles. At the same time, mediastinal mass would not have any manifestations of your air bronchograms, however, would show your hilum overlay sign, wherein there would still be the presence of the hilar vessels and structures beyond the mediastinum. So going back to our patient's chest radiograph would form your obtuse angle, would not have any signs of your air bronchograms with the presence of your hilar vessels. And with that, we can say that our mass belongs to the mediastinum. Next, we compartmentalize our mediastinum to further limit our differential diagnosis. Anatomically, we can separate our mediastinum into 4 compartments. The major compartments would involve your superior and the inferior compartment, wherein the inferior compartment would comprise of your anterior, middle, and your posterior compartment. The superior and the inferior compartment may be separated by forming an imaginary line from the manubrium sternal joint up to the level of the forethoracic vertebra. Meanwhile, your inferior compartment may be separated into your anterior, middle, and posterior compartment. The anterior compartment would be behind or posterior to the sternum and anterior to your pericardium. This is where you usually find or locate your thymus and your lymph nodes. The middle compartment would comprise of your pericardium, the heart, the great vessels, and also your major airways. As for your posterior compartment, it is located behind the heart and would usually contain your esophagus. So radiologically, these 3 main mediastinal compartments may be separated on lateral view of your chest radiograph using the Felson's division of your thorax. So the anterior and middle compartment may be separated by forming an imaginary line from the anterior to the trachea and posterior to the inferior vena cava. Meanwhile, your middle and your posterior compartment may be separated by forming an imaginary line 1 cm posterior to the anterior margin of the vertebral bodies. So going back to our patient, using the Felson's divisions of the mediastinum, our patient's mass is located just posterior to the sternum and is anterior to the first imaginary line that would separate your anterior and the middle mediastinum. Hence, we can say that our mass is located in the anterior mediastinum. So anterior mediastinal masses is often an incidental finding wherein most patients are asymptomatic unless there is compression or displacement of your adjacent structures caused by the large mediastinal mass. So the signs, these are some of the clinical manifestations of patients with endotracheobronchial tree. Hemoptysis may occur in 10% of children due to the irritation of the tumor to the bronchus, while chest pain, hoarseness, and brassy cough are associated with impingement of the recurrent laryngeal nerve, and facial or upper extremity swelling is associated with compression of your superior vena cava. Systemic effects such as your fever, night sweats, and weight loss may be secondary to the compression of the tracheobronchial tree, causing recurrent lower respiratory tract infections. However, it may also be due to the increased caloric demand by your dyspnea, or it could be associated with your malignancy. When we think of the anterior mediastinal mass, we should remember the 4 T's as our main differential diagnosis. The 4 T's will include your teratomas, THYMOS, terrible lymphomas, and your thyroid disorders. Our primary differential is your mediastinal germ cell tumors, which are the most common form of extragonadal germ cell tumors that results from the failure of the migration of the primordial germ cells to the gut, along the gut. It has a varying biologic behavior wherein it may be constant in size, grow gradually or rapidly, that would cause your compression symptoms. Teratomas are usually benign, while yolk sac tumors, germinomas, embryonal carcinomas, and choriocarcinomas would be malignant, favoring which would yield a poorer prognosis. On imaging, teratomas would often appear well-defined, unilocular or multilocular, which would contain fluid, soft tissue, and fat attenuation. In some instances, calcifications may also occur. Malignant forms of your germ cell tumors would appear similarly to your benign counterpart, however, would appear more solid and homogeneous than the benign forms. So comparing our patient's CT scan with a representative scan, we may consider germ cell tumors as our diagnosis since the characteristics of the mass is similar to that of germ cell tumors. It is non-homogeneous. It is non-homogeneous with multiple attenuation values due to the fat, fluid, and soft tissue content. The appearance favors a more benign form of your germ cell tumor. However, at this point, we cannot totally rule out the possibility of a malignant germ cell tumors since further testing such as your serum tumor markers and tissue biopsy is warranted. Our next differential diagnosis will be your mediastinal lymphomas, which is actually a relatively common disease entity in children associated with painless lymphadenopathy. It has an infiltrative nature with rapid progression and associated with the following symptoms. Imaging would show a homogeneous soft tissue anterior mediastinal mass with mild to moderate contrast enhancement associated with irregular contours and surface lobulations, and sometimes would often show mediastinal lymphadenopathy. Going back to our patient, the symptoms of fever was acute with weight loss that may have been secondary to the easy fatigability of the patient. On physical examination, she did not have any palpable lymphadenopathies, and additionally, our mass is non-homogeneous in contrast to the usual CT scan findings of your lymphoma, making this diagnosis less likely. Another consideration is THYMOMAs, which are the most common primary neoplasms in the anterior mediastinum that is usually diagnosed in adulthood. It is rare in children and would often manifest with signs and symptoms of your myasthenia gravis, as listed here. Imaging would show a round encapsulated mass with well-demarcated borders and would appear homogeneous. Our patient does not fit the demographic profile since he is only 5 years old and has no associated signs and symptoms of your myasthenia gravis. In contrast to THYMOMAs, his chest CT scan was non-homogeneous, and with these findings, THYMOMA is also unlikely. We may also consider the possibility of a thymolipoma in a patient wherein it is a rare, benign, well-encapsulated thymic tumor that accounts for 2% of thymic neoplasms. It would be composed of a mixture of your adipose and thymic tissue and the usual fat content at around 50 to 85%. They are usually slow growing and is already large at the time of your diagnosis. Although it is rare, especially in children, we cannot totally rule out the possibility of the thymoma since our chest CT scan findings show an inhomogeneous density with a noticeable fat content. With that, we may still consider this as our diagnosis. Lastly, mediastinal ectopic thyroid is a rare entity that accounts for 1% of all mediastinal tumors. It often manifests in adulthood and occurs due to the failure of the thyroid gland from migrating to its normal position. There would be an increase in demand in the thyroid hormones, which would increase your thyroid-stimulating hormone, hence cause your further growth of the mass. It is associated with signs and symptoms of your hypothyroidism. On imaging, ectopic thyroids would often appear heterogeneous with a high CT density, higher than the regular soft tissue brought about by the higher iodine content of the thyroid tissues. Based on the very low incidence of your ectopic thyroid, absence of signs and symptoms of your hypothyroidism, and absence of the high density mass in our patient, ectopic thyroid is also unlikely. So going back to our list, we have ruled out the possibility of lymphoma and thyroid disorders as the cause of your anterior mediastinal mass. However, at this point, we cannot totally rule in or out the remaining differential diagnosis as further tests such as your serum tumor markers are necessary for a more definitive diagnosis. For now, our working impression is an anterior mediastinal mass to consider germ cell tumors versus a thymolymphoma.
Are there any questions at this point? Akara.
Can you expound on the past medical history of bronchial asthma of these patients? How the patient was diagnosed, what were done, and do you agree with the diagnosis then?
When we received the patient was diagnosed with asthma when he was 1 year of age, and it was just one and only diagnosis of your asthma due to the response to the bronchodilator therapy during that time. Although the patient was never given maintenance medications and never had an attack afterwards. The patient did not, besides that, there was no respiratory difficulty. At this point, for doctor, since he did not have any, when we received the patient, he did not appear to have any signs that he had asthma. So on admission, the patient was in respiratory distress, hence oxygen support was given. Chest X-ray revealed the progression in the size of the mass, now displacing the heart to the left. TCBS plans to do biopsy of the mass, hence workup was done preoperatively. CBC showed mild anemia with leukocytosis, accompanied by the acute symptoms of fever and dyspnea. A concomitant pneumonia was also considered, hence ceftriaxone was given. Prothrombin and partial thromboplastin time left were all normal. Since there was progression in the size of the tumor, a repeat of the serum tumor markers was done, which was still within normal range. Due to the progressive respiratory difficulty of our patient, an emergency anterior mediastinotomy for biopsy of the mediastinal mass was done. It revealed mature adipose connective tissue with cystic fluid that was negative for malignant cells. Impression at this time was of benign fibroadipose tissue. Ideally, we may proceed already with the sternotomy and excision of the mass. However, they were not financially prepared. So the patient was then transferred to the pediatric ICU for post-op monitoring, where a repeat chest X-ray still showed their semi-circumscribed mass with better aeration of the right lower lung. Post-operatively, the patient remained stable and was managed accordingly. He subsequently underwent the contemplated procedure, where operative findings showed an anterior mediastinal mass that occupied the whole anterior mediastinum, with the right lateral extent accounting more than half of the right thoracic cavity. The mass was closely related to the pericardium, right pleura, right phrenic nerve, superior vena cava, and left innominate vein. The mass contained a mixture of your solid and cystic structures with an estimated size of around 17 by 15 by 6 centimeters. There were multiple post-inflammatory adhesions noted at the anterior pericardium. Post-operatively, the patient improved with no signs of your respiratory distress. CBC still showed your leukocytosis with predominance of your segmenters. Pericardial kilogram stain and culture was likewise done, which yielded negative results. On repeat chest X-ray, there no longer shows the previously noted homogeneous density. However, still showed hazy densities at the inner lungs, so ceftriaxone was continued. Also, our next question here is what happened to the chest wall mass noted on physical examination? Well, the previously noted mass or swelling of the anterior chest wall was no longer appreciated after excision. It was not a separate tumor, but rather an extension of the anterior mediastinal mass due to its large size. bulging through the chest wall. This may explain why the mass was fluctuant and non-tender, and this was further proven intraoperatively when the mass was separate from the chest wall. There have been case reports with similar manifestations of the swellings in the supraclavicular region and the anterior chest wall, postulated to have been extensions of the mass that also vanished after removal of the said mass. HISTOPATH showed a light brown to dark brown, firm rubbery ovoid mass measuring 11.5 by 11.5 by 7.5 centimeters with a light brown smooth outer surface. Uncut sections include multiple loculations measuring 1.5 by 1.5 to 6 by 3 centimeters with a light brown inner lining and a wall thickness of 0.1 centimeters containing your serous fluid. A focal solid area was also containing creamy white granular material measuring 3 by 1.5 centimeters was noted. Microscopically, it showed a benign germ cell tumor composed of your fibrocollagenous cystic structures lined by stratified squamous to respiratory epithelia associated with sebaceous gland, hair follicle, keratin flakes, mature adipose tissue, mature hyaline cartilage, pancreatic, and intestinal acini. There was no immature neuroepithelial tissue identified, and sign out for the specimen was a benign mature teratoma. Due to his continuous improvement, he was eventually extubated by the second post-op day with oxygen supplementation gradually weaned off. Chest tube was removed by day 4 post-op, and ceftriaxone was completed for 7 days. Since the patient's histopathology revealed benign findings, no chemotherapy was necessary. He was then discharged in 2. Final diagnosis for our patient was a mediastinal mature teratoma and pneumonia. As an update, the patient was able to follow up 2 weeks post-discharge and denies any cough or respiratory difficulty. So, germ cell tumors are neoplasms that arise from the cells of the germline. It is pluripotent, wherein the cells are capable of differentiating into different types of specialized cells found within the body. With that, it has a varying biologic behavior dependent on the size and location of the tumor. Its incidence is dependent on the age of presentation. At a younger age, the incidence is low at around 3.5%. However, as the child reaches adolescence, there is an increase in incidence by 2.5-fold in females and 6-fold in males. Primordial germ cells are located in the yolk sac and colonize the hindgut prior to migration to the gonadal ridges along the gut. The distance of the migration enforces quality control by selecting your healthy primordial germ cells capable of successfully navigating to the developing gonad. However, there are instances wherein the germ cells are unable to successfully migrate to the said site. While most of these ectopic cells will not survive, some may persist or develop malignant transformation. The most common site of your extragonadal germ cell tumor would be your mediastinum, followed by your retroperitoneum, pineal gland, and your sacrococcygeus. These are the different types of your germ cell tumors, and we focus our attention to the benign form of germ cell tumors, which was seen in our patient, which is the teratomas. Teratomas are the most common types of your germ cell tumors composed of at least one of the 3 germ cell layers. Their endoderm would comprise of your respiratory and intestinal epithelium, while your mesoderm would contain your fat, cartilage, bone or smooth muscles, and the ectoderm, which would comprise of your skin, hair, sweat glands, and tooth. There are 2 main types of your teratomas. The mature teratomas are well demarcated and displaced rather than invade adjacent structures. They are usually cystic, uni or multiloculated, and contain well-differentiated adult-type tissue from different germ cell layers. It has a variable attenuation containing your fat, fluid, soft tissue, or calcifications. Meanwhile, your immature teratomas are usually solid with undifferentiated or embryonal appearing tissue, particularly your neuroepithelium. It is associated with your hypercellularity, increased mitotic index, and your nuclear atypia, which are all indicative of malignant transformation. So looking back at the patient's gross specimen, it is round and cystic and more comparable to mature teratomas. The mediastinal mature teratomas are slow-growing, benign neoplasms of the anterior mediastinum caused by urofaulty embryogenesis, comprising 1 to 3% of all germ cell tumors and 24% of your mediastinal neoplasms. Like most other causes of your anterior mediastinal mass, patients with teratomas are usually asymptomatic unless it is large enough to cause compression symptoms, such as in our patient's case when he had cough, dyspnea, and easy fatigability. Other clinical manifestations of mature teratomas would include trichophysis, which is expectoration of the hair, an extremely rare and pathognomonic manifestation of your teratomas, and associated with the rupture of the tumor through the tracheobronchial tree. Hemoptysis is another clinical manifestation of your teratomas, which is brought about by the tumor rupture into the tracheobronchial tree as well. Ancillary tests, such as your chest radiograph, may identify the mediastinal mass. However, it will not be able to clearly identify the cause of the tumor. Mature teratomas will often appear rounded or lobulated with sharply marginated borders, which is similar to the other causes of your mediastinal mass. In some or rare instances, there may be identifications of your calcifications through bone or teeth, which would be pathognomonic of your teratomas. Chest CT scan would be the modality of choice for mature teratomas, wherein it will be helpful in determining the location and the extent of the tumor, as well as define the characteristics of the mass. In our case, mature teratomas will usually appear homogeneous, containing soft tissue, fluid, fat, or calcium, or the combination of the four. So it is also helpful in evaluating the adjacent structures, as well as possible complications of your teratomas, such as your rupture. The representative scan projected showed a ruptured teratoma with air and fat. So tumor markers are recommended in patients suspected of having mediastinal masses, particularly your germ cell tumors, as it may help in the diagnosis and prognostication of patients. In the long run, it may also be helpful in monitoring patients' disease burden and activity. So your alpha-fetoprotein is a glycoprotein synthesized by your fetal liver and yolk sac that is normally elevated in infants, however would reach adult levels by 2 years of age. If elevated, it may indicate a non-seminomatous germ cell tumor, particularly the yolk sac tumors. Beta-human chorionic gonadotropin, or your beta-HCG, is a peptide hormone commonly produced in pregnancy that contains progesterone. Elevated levels would indicate either a seminoma or non-seminomatous cell tumors, particularly your carcinomas. If the tumor markers are within normal limits, such as in our patient, it may point to a more benign form of your germ cell tumor. Despite the different diagnostic modalities, tissue biopsy remains the mainstay of diagnosis to determine if the mass is benign or malignant. Needle aspiration or core needle biopsy may be done, however, excision biopsy remains to be the most sensitive and will be confirmatory of our diagnosis. Aside from confirming the causes of your mediastinal tumors, we must also take into consideration the different complications associated with mediastinal masses. So superior vena cava syndrome is a rare complication in children that results from the obstruction of your superior vena cava by the compression effects of the mass, causing reduction of your venous blood flow to the head, neck, and upper extremities. Patients with your superior vena cava syndrome will have edema or swelling of the neck, head, and upper extremities with appearance of your collateral chest wall veins due to increased venous pressure and sometimes cyanosis. Other symptoms are listed below. It is a serious complication that would rapidly progress, and management would include the removal of the mass causing the obstruction. However, it is not possible, if not possible, radiation or chemotherapy or steroids may help decrease the size and inflammation of the mass. Going back to our patient, the mass was closely related to the superior vena cava. Fortunately, we were able to intervene before the mass could grow any further, so that there would be, we were able to prevent the deleterious complications from happening. Another complication associated with your teratomas is the egg structure. It usually occurs spontaneously and is hypothesized to be due to the autolysis of your tumor walls brought about by the enzymes within the tumor, particularly the pancreatic tissue. Although there are reports saying that it may also be due to infection or your ischemia. These are the following signs of rupture and the associated signs and symptoms. It would often manifest as consolidation or effusion on chest X-ray or CT scan. It may also cause inflammation or adhesions within the thoracic cavity, making surgical management more challenging. Although a rare complication, we may consider this in our patient due to intraoperative findings of multiple post-inflammatory adhesions at the anterior mediastinum. However, this finding may also be circumstantial. Another complication that may occur in patients with large anterior mediastinal masses are re-expansion pulmonary edema, which may occur after removal of the mass, causing sudden re-expansion of the lungs and would even cause worsening of the respiratory condition. It is usually manifest in patients who belong to the younger age group or those who had a chronic atelectasis of at least 72 hours. Its pathogenesis is due to the chronic lung collapse that would harden the microvessels, pulmonary microvessels, and after removal of the said mass, there would be rapid stretch or expansion of these microvessels, hence forming these symptoms. Fortunately, our patient did not have these symptoms after the removal of the teratoma. As for the treatment of your germ cell tumors, all germ cell tumors, particularly the 9 mature teratomas, the mainstay therapy remains to be the excision of the mass via lateral thoracotomy or median sternotomy with evaluation of regional lymph nodes if necessary. This should be done as soon as possible to prevent further growth of the mass, compression symptoms, rupture, invasion of adjacent structures, malignant transformation, or developed infection. In the event that the mass has malignant potential, multimodal therapy, including neoadjuvant chemotherapy, with serial monitoring of tumor markers and signs, and followed up by excision of the residual mass, is recommended to increase the survival of patients with the said diagnosis. In benign forms of your germ cell tumors, such as mature teratomas, patients who undergo complete excision or resection of the mediastinal mass would have an excellent prognosis and fully recover with a disease-free survival of nearly 100%. Monitoring of tumor markers and serial CT scan is not necessary. If determined to have malignant potential, the prognosis would be poorer at around 20 to 27%. However, the 3-year survival will increase to 45 to 80% provided that the patient undergoes multimodal therapy. Monitoring of the disease burden and activity via serum tumor markers and chest CT scan should be continued postoperatively due to the high incidence of recurrence, especially to those with malignant. So in summary, anterior mediastinal masses are often an incidental finding, and narrowing our differential diagnosis based on the clinical presentation and chest radiograph alone is difficult. Symptoms occur as a consequence of the size of the mass causing compression of adjacent structures, and CT scan of the chest may be helpful in evaluating mediastinal masses, but tissue diagnosis is still the mainstay for diagnosis and prognostication of patients. Although mature teratomas are benign, removal of the mass is still warranted as soon as possible to decrease the likelihood of malignant transformation, rupture, infection of the teratoma, or simply to prevent it from growing enough to take your breath away. Thank you and good night.
Thank you, Dr. for your comprehensive discussion. Are there any questions? From the according the words to the discussion. Dr. Hill.
Good evening. I'm Dr. Yolo from Pathology. I must apologize for our coming in rather late into the discussion. I've heard the very well executed discussion. I must congratulate Dr. Rago. I was the one on board when the tumor was being resected. Of course, I see Dr. Sanchez here. My question is, I remember this case wherein a frozen section was requested, and I was just wondering what would be the value of a frozen section if a diagnosis or an impression of teratoma was very well entertained. Just like in your discussion, if you try to nick or time which will result in a complication. The frozen section was not very rewarding. If I recall, the first two tissue that was submitted to us turned out to be simply non-specific connective tissue like fat and fibrocollagenous tissue. I do not know if that was very rewarding to the surgeons on board. So my question is, what could have been the value of doing a frozen section for a cystic teratoma?
During the time that we did the emergency anterior mediastinostomy, we were considering that it was a germ cell tumor. However, we cannot totally rule out the possibility of a malignant type of your germ cell tumors. In cases of malignant types of your germ cell tumors, we still need to usually we do neoadjuvant therapy prior to the excision of the mass because it could infiltrate or invade the adjacent structures, and it could be a very bloody procedure if it was done during that time.
Yes, I do understand that. This is an 11.5 centimeter tumor, correct?
Yes, ma'am.
And I do not know how will you sample an 11.5 centimeter tumor that will give you a very straightforward diagnosis. So only nips of tissue submitted to us. I don't think submitting small pieces would be rewarding in the first place. So my thinking is that well, you could have just removed the tumor that is surgically feasible and safe, and the specimen is sent to us in toto and block, and then we can assess it and evaluate it more thoroughly instead of giving us nips of tissue, which I don't think was even helpful to the surgeon and perhaps to everybody on board. I'm pretty sure everybody knows frozen section is a very expensive procedure, and well, that's just my point. Thank you.
Thank you, Dr.
Sanchez.
Thank you, Dr. Yol, for your question. But at that time, there was no definite indication that this was a teratoma. It was actually a surprise that this turned out to be a mature teratoma. But initially, everybody believed because of the rapidity of the expansion and the growth in a 5-year-old, we were led to believe that this indeed was a malignant tumor. And so a biopsy would give us the benefit of neoadjuvant treatment in order to shrink the tumor and do a more complete resection at a later time when it has responded.
Thank you, Doctor. Are there any questions? Or questions from the other institutions? So if you were to give the adjuvant treatment, what are the most common ones?
So in cases of your malignant germ cell tumors, the neoadjuvant treatment would be a platinum-based chemotherapy that would comprise of your bleomycin, etoposide, and your cisplatin. Usually would be given every 28 days for at least 6 doses. And then it would usually have monthly serum tumor marker monitoring and chest CT scan so that we could take note if there is already decreasing in the size of the mass. In cases if there is a decrease in the size of the mass, then we can push for excision of the residual mass, and then followed by still with the serial monitoring of the tumor markers. Because if there would be an increasing in the size of the tumor markers, then we need to do salvage chemotherapy.
Thank you. Other questions? If none, you might have other questions after our answers. So we are very fortunate to have two good reactor space at this evening. So first is our surgeon, Dr. Sanchez. So Dr. Sanchez is the head or the chief of section of the PCBS Department of Surgery at the University of Santa Tomas, and also the head of the PCBS at the De Los Santos Medical Center, an active medical staff at various hospitals, including the UST Hospital, De Los Santos, Cardinal Santos Medical Center, and Chinese General Hospital. He is also an associate professor at the Faculty of Medicine and Surgery of UST, and a member of several college and association. Let us all welcome Dr. Josefina Sanchez, MD, FPCCS, FPP, DACSI, FPCSB. Thank you.
Perhaps we can project the intro pictures. Okay, so the initial problem that was presented to us was we were really overwhelmed with the extent of the mass. And do we have the initial? And we were limited by the ancillary procedures because these were all done outside, and this patient could not afford a repeat CT scan prior to the procedure, and that these were imaging, and the only CT scan was done 8 months ago. So I think even the initial reading was that of a solid tumor, and there was no indication that it was cystic at all. There was no mention of calcification. That would give us a clue that we were dealing with a teratoma. And with the rapid expansion or expansile in the last last few weeks, we were made to believe that indeed we were dealing with a malignant germ cell tumor. So we proceeded with doing an initial biopsy using an anterior mediastinotomy, but it was a limited amount of exposure. So what we got was somehow inadequate. That's why it just showed fatty tissues, but we were sure we were able to get the capsule of the tumor, but turned out to be still just probably the superficial portion of the tumor. That's why we were not able to get the deeper section of the specimen. But because of the progressive respiratory distress in this patient, mind you, this patient was, we received this patient from the other hospital intubated already. Okay. But since we were not able to extubate this patient after the biopsy. So this patient, in the matter of several days, we rescheduled him for sternotomy and the tumor, and we were ready for the possibility that this is going to be a very bloody resection. But fortunately, we were able to resect it in total, and the adhesions in the mediastinal area were well delineated. So fortunately, the mass was excised completely. Show the operative. And it was almost as big as the mediastinal organs, no? The heart. So, and in the biopsy, I believe we will be given the details by our pathologist. So, even after excision, we were not sure whether what type of mass this is. The final diagnosis really came as a surprise. So anyway, in this very young age, we think more of malignant mediastinal masses, and especially with this type of behavior. And mature teratoma, we see that more in the adult population, but not in this very young age. I believe this is the youngest mature teratoma I've seen, and even the presentation was really baffling that we were not able to proceed in the usual fashion that we go treat, handle mature teratoma, which is an outright excision. So, and happily, this patient ended well. Thank you.
Thank you, Dr. Sanchez. So our second reactor is Dr. Riolo. So Dr. Riolo is a member of the Board of Examiners of the 50th Board of Pathology, Philippine Society of Pathologists from 2014 to 2016, and an active medical staff at various institutions such as UST, St. Luke's, and also an associate professor at the institution, at those institutions, UST and St. Luke's Faculty of St. Luke's College of Medicine, and also an associate professor and head of histology at the Department of Anatomy, St. Luke's College of Medicine. He is also an active staff in the Department of Anatomic Pathology of UST Hospital, and a consultant surgical pathologist and cytopathologist, Corporate Wellness Center Medical Electric Company Compound, and also member of various societies and associations. Let us all welcome Dr. Rowan Yolo.
Thank you very much for the kind introduction. I think just as I was coming in, I believe Dr. Go made a very good pathology discussion already. I think she discussed very splendidly 90% of pathology, and I must congratulate her. So, these are the slides that were shown earlier, and this is the external surface. It's rather well circumscribed. It is smooth. There is no evidence of any rupture. I am very much impressed in the skill of our surgeons in removing such a very huge tumor in a very dangerous anatomy of the chest, the mediastinum. And this is the cut section as what was projected earlier. We see a partly solid and a partly cystic lesion. Now, what's very, very interesting in teratomas of the mediastinum is that they do not really manifest the way that we see mature teratomas in the gonads, in the ovaries. In the ovaries, we usually see the classic hair, we see sebaceous material, and very prominently are ectodermal odontogenic elements like your teeth. That's why I believe in one of the slides that was projected a while ago in the X-ray, we see a set of teeth, and that's very diagnostic. Now, you're very lucky if you see something like that. Now, in the mediastinum, we don't see that classic presentation. All right, that's why I guess pre-operatively, teratoma was not highly on top of the list among the differential. Now, of course, what was worrisome though when we saw this material was, of course, there were solid areas. Well, in here in the very center, we do see visible fat, all right, as well as in this particular areas. And of course, what was quite prominent are cystic material, which was filled from serous fluid to hemorrhagic fluid. And under microscope, we see all benign ectodermal, mesodermal, and endodermal elements. So it's a walk to the park in basic histology. And let's see what we saw. And I hope you can identify them. You will recall your basic histology. So this is simply ectodermal tissue, all right? So stratified squamous epithelium, all right? Underneath, of course, is fat, and this recapitulates skin, cutaneous surface, okay? Cutaneous surface. And of course, here we see the keratinizing portion of that ectoderm, and we see here the keratin flakes, which is very classic of stratified squamous keratinizing epithelium of the skin. In here, can you identify what is this? Remember your practical exam in histology? Alright, so this is, let me get a closer magnification. There we go. We see stratified epithelium to what seems to be pseudo-stratified. You have, what's this? Cilia. Remember the cilia? And of course you have goblet cells. So this is your respiratory epithelium, right? Pseudo-stratified columnar ciliated epithelium with goblet cells. Okay, remember in first year, one goblet cells, one half. You only get one half of the point, right? So our professors always wanted the complete nomenclature, right? So this is respiratory epithelium. And then, what about this? Anybody can identify what tissue is this? Oops. So these are small acinar structures of the serous type. and you see them in lobules. So this is normal pancreas, right? Pancreatic tissue. So endodermal in origin, okay? And this one, these are obviously acini again. Well, they're glands. You see a lumen inside. And of course, the epithelium is made up of this vacuolated cells, clear cells, that is mucin containing. So these are mucus acini, right? So mucus acini, the ones that we see in respiratory tract and in the GIT. Okay, so mucus producing acini. Just there in the background, here, in the background, we see smooth muscle, right? So it reminds you of what you see as muscularis propria in many organs. This one, anyone identify this? This violaceous looking material. Cartilage, very good, very good. Buti pa si Dr. Sanchez, remembers his histology. Mukhang puno kaya, Doctor, no? Histology ni puno. Right, very good. This is cartilage. And of course, I guess everybody can figure this out. It's just fat, okay? Adipose tissue, okay? Remember your signature appearance of the lobules. What about this one? Well, these are complex tubulo acinar structures, and they are likewise ciliated, and well, they perhaps remind you of glandular structures that arise from the GIT. Okay, though at this point I do not know honestly the differentiation towards to what particular organ. This one, this is salivary gland tissue. Okay, we see this, remember this mixed type of acini, mucus and serous, and we see the seromucus type. Remember the serous demilunes, what our old professors called the crescents of Januzzi, all right? The demilunes of Januzzi, very typical of mixed acini of the salivary gland. Again, we see respiratory type of epithelium, complete with the cilia there on top. So, everywhere we search for, we see normal histologic components. What makes a teratoma malignant? Twofold. Number one, you have immature elements, in particular your immature neuroglial component. And number two, you can have outright neoplastic transformation, like squamous cell carcinoma, rhabdomyosarcoma, choriocarcinoma for that matter, or other malignant components that was discussed earlier, like your endodermal sinus tumor or your Yoxa tumor. Okay, so those are the possible neoplastic components that are malignant. So I just like to add a few notes from our discussant here. So the anterior superior mediastinum is the most common site where you have the extragonadal teratomas or germ cell tumors. However, quite interestingly, there are reports where you can find them also in the posterior mediastinum. Well, I don't know if it's exactly located only in the posterior mediastinum, or perhaps it is a tumor so huge that it encroaches even in the posterior mediastinum. I haven't read much the entire article though. This was mentioned a while ago. Benign mediastinal teratoma accounts for around 60% of all mediastinal germ cell tumors. And here we see an interesting association of teratomas, all right? They may be associated with Klinefelter syndrome and may be associated with leukemia, in particular acute myelogenous leukemia in the future. So we do see perhaps some association with some hereditofamilial syndrome as a component. In must forgive me for this busy slide. It just shows you the different possible pathologies in the mediastinum. And I just want to call your attention here to the teratoma. All right, it has an equal predilection for both sex, both genders, and the markers were there. I think our clinicians did the markers, and I'm very happy about that because what happens sometimes is that when we come up with a diagnosis of a malignancy, that's the only time that they request for the markers. So it's very important, if you think that you should be or you will be dealing with a possible germ cell tumor, get a baseline. So it's part of the workup. Okay, don't wait until the tumor is out because it becomes useless already. Okay, so get a baseline, and I'm very happy that the clinicians did get a baseline, and it turned out to be negative, or I mean normal rather. I'm sorry, normal. This is just a tabulation showing you the different possible lesions that you can find in the different parts of the mediastinum, and in particular, we're focusing on the anterior mediastinum. That's where the tumor is located. And of interest, you have the 4 T's that I'd like our young colleagues here to remember whenever you deal with lesions in the anterior mediastinum. And what are they? Thyroid, number 1, mediastinal thyroid. Number 2, your thymus, of course. Number 3, the teratoma or germ cell tumors, and number 4, the terrible lymphomas. Right? So the hematolymphoid. So of course we do have a lot of other possibilities, and it's very helpful that you remember the following lesions in particular component of the mediastinum. So there you go. Just all discussed by our discussant, right? It's a neoplastic, not a developmental malformation. 50% presents with cough, dyspnea, and chest pain. I think we all heard that a while ago. And most of the symptoms are the result of compression. And I'm I learned about that. What was that condition? Where you have that constant compression, and then all of a sudden they remove the tumor. There is a re-expansion, pulmonary edema. Yes, that's something I learned. A very interesting phenomenon, and it's a very serious complication. It can be fatal, right? Re-expansion, pulmonary edema. Tumors that adhere to the lung, to the pericardium, blood vessels, are either malignant or perhaps a ruptured tumor that can incite an inflammatory response or adhesion. Okay? Benign mature teratomas, of course, have an excellent prognosis. I think we saw about this derivative of the germ cell, equal frequency in both genders. It's a slowly growing tumor. This is a 5-year-old boy. Is that correct? And I find it interesting, a 5-year-old boy with a teratoma. I think I'm going to sit down with you, Jamie, and Dr. Sanchez. Let's write a paper on this. Do a literature research. There is no 5-year-old on record. Have you seen any 5-year-old? Voila. So this is a worthwhile, reportable case. Okay, I think we'll talk and sit down, collaborate with our surgery colleagues, and let's report this. Okay, it's interesting. Okay, so it was very well discussed. So you all see the histology: ectodermal component, mesodermal, endodermal. Of all the sites, the extragonadal sites, the mediastinum is the most common. We see all these benign, normal, well-differentiated cells. When they're all benign and mature, we call it mature teratoma. If you have a malignant component or immature component, we call it an immature teratoma. But mind you, even a mature teratoma can harbor a malignant component. All right, you must remember that. You must remember that. Okay. I think Jamie, you showed something like this a while ago. So there's your germ cell. You can differentiate towards the germ cell seminoma in the testis, germinoma in the mediastinum, this germinoma in the ovaries. Okay? Or you can differentiate towards the totipotential capacity lineage. So you have there different degrees of differentiation. So if you have the embryonal component, then you have what we call an embryonal carcinoma. Of course, that's always malignant. Or you can have components of the embryo, either extra-embryonic or embryonic. So if it's embryonic, then you have the differentiation towards the mature elements, ectoderm, mesoderm, endodermal cell lines. And this is what you have here, teratoma. Towards the extra-embryonic tissue, you can have either differentiation towards vitelline structures, like the yolk sac, or trophoblast or placental structures, in which case we have the highly malignant choriocarcinoma and your endodermal sinus tumor. And that's the reason why we have these tumor markers, the beta-HCG and the alpha-fetoprotein. Okay? So again, just showing you the pathway by which a teratoma is derived from from the embryonal cell line, okay, embryonal cell line that is, and we see that as a defect that could happen at the second to the third week of embryonic development. Okay, so once again, we see a germ cell tumor differentiating towards the mature pathway. Okay, and then we have there your mature cystic teratomas, one of the examples. And like I mentioned a while ago, mind you, even if it's mature, a malignant component could arise within that mature pathology. And that's why I always tell my residents, we have to sample the tumor extensively. Okay, so try to search and sample every corner, every solid part. All right, every solid part. You may harbor a very, very subtle or seemingly small focus of any of these malignant tumors. Okay, I just want to show you this example of a malignant or immature teratoma, wherein you see a predominance of the solid, consolidated area in proportion to the cystic area. Okay, so the more solid your tumor is, the more likelihood that perhaps this might be malignant rather than benign. Okay, so so this is our final diagnosis, and again, I must congratulate our discussant for a very erudite discussion. Although there's one thing that I missed here, and residents forgot to do it. What do you think in the diagnosis? You forgot to weigh, right? It could have been interesting. I don't know if there was any documented the weight. Okay, it's something that we missed. I always tell my residents, these tumors that are rare and like the old teratoma, vegetal teratomas, we have to always weigh them. Okay, to always weigh them. So I believe, judging from the picture, it might weigh almost close to maybe 500 grams or so. Okay, so judging from that, it's something that we missed to document. Okay, so thank you very much, and thank you for the kind invite.
Thank you, Dr. Yola. Do you have any questions for Dr. Sanchez or Dr. Yola? If none, it has been a very fruitful night. So, do you have any announcement?
Thank you very much. Congratulations to UST. So, before before you end, I think Gachi gave you the gifts. Anyway, so don't forget the anniversary is on March 19. And thank you very much. This is our last inter-hospital for 2019 to 2020. I remind you now the poster and abstract deadline is on February 28th. So please do submit so that you can join the research contest presentation or the oral poster presentation. Anyway, for next year, we will update you. So maybe there might be a change of the format of the inter-hospital conferences, but we will do update your training officers. Thank you very much.
Thank you. There are no more announcements. Good night, everyone. Thank you again, Dr.